Thank you, and enjoy the session today. Our section will be, this is the second day of a 2-day program, and the first session will be hosted by Ron Plotnik. Ron joined the faculty here at the University of Rochester Medical Center in 1991 and has been a critical part of its history and growth. He's been the cornerstone of the cornea service, treating and managing some of the most difficult anterior segment cases. Dr. Plotnik has additional postgraduate degrees in medical management and a master's of business administration from the Simon School, and is a vital part of our administrative effort to improve the Eye Institute in many domains, serving as Director of Operations, Quality Assurance Officer, Compliance Officer, and Electronic Medical Record Clinical Liaison. He's also served as the Associate Medical Director of the Rochester Eye and Human Parts Bank, and he received his Bachelor in Science and Medical degrees at the University of Michigan. After completing an ophthalmology residency and serving as Chief Resident at the University of Wisconsin-Madison, he did his Cornea and External Disease Fellowship at the University of California, Davis. He really has helped to make me a better chair, and I appreciate his dedication to the Eye Institute. Ron, thanks for moderating the session this morning. Go ahead and take it away.
Thank you very much. I would like to also welcome everyone to the 65th Rochester Ophthalmology Conference program, Section 5 Cornea and Retina. I'd also like to thank Steve Crawford and team and Dr. DiLoretto for hosting the conference. And thank you for getting up so early, especially those a little west of here. And I'm going to share my screen. I would first like to introduce Dr. Rachel Wozniak. She'll give our first lection. She is a Flum Eye Institute Assistant Professor of Ophthalmology. She's a clinician scientist who's part of our cornea service. She's an accomplished surgeon who's also involved in medical student, resident, and corneal fellow education. Dr. Wozniak's research interests involve understanding the pathogenesis of corneal infections and their resistance to antibiotics. Her aim is to develop novel antibiotic treatments to treat corneal infections. Her interests have resulted in multiple grants, including a K Award from the National Eye Institute, a Career Development Award from the Research to Prevent Blindness, and has a patent pending for a new therapeutic for treatment of corneal infections. Dr. Wozniak received her medical degree and doctorate in molecular genetics from Tufts University of Medicine. She came to the University of Rochester for her residence and completed her subspecialty training in cornea and external disease as a HEED fellow. Please welcome Rachel as she presents Understanding Staphylococcus aureus Keratitis, Redefining Diagnosis and Prognosis.
Ron, are you able to unshare so I can share? Perfect.
My apologies.
No, no worries. Okay, so thank you so much for the introduction and good morning, everyone. Really grateful to be here and be part of this program and having the great honor of kicking us off bright and early on a Saturday morning. So hope everyone has got their coffee. And so we'll dive right in. So the title of my talk is Understanding Staphylococcus aureus Keratitis, Redefining Diagnosis and Prognosis. And sort of admittedly, that's a pretty ambitious title, but I'm hoping over the next sort of 15 to 20 minutes, I can kind of show you some of the work we're doing in the lab and how I think some of the basic science research can really relate to our clinical practice and may change how we think about this pretty blinding disease, which is corneal ulcers. So most of you who know me know I'm sort of the department resident microbiologist. I've had a really long standing interest in bacterial infections, stretching back to my graduate school days. And from the perspective of understanding antibiotic resistance and how do we develop treatments that can overcome circulating resistance, but also understanding a little bit about the basic biology of bacterial infections. What is it that bacteria produce that make it so destructive and so virulent in the human body, not just in the eye? And so becoming a cornea specialist was fairly deliberate on my part, primarily for these patients, right? We see a fair amount of bacterial corneal infections as shown here on the right. And seeing these patients on a pretty regular basis kind of helped enable me to continue to live my clinician scientist dream in terms of overlapping my clinical practice as well as my basic science research interest. So just with that kind of being said, to frame the problem here, everyone has seen these patients come across their door at one point or another. And we all know that bacterial infections in the cornea can be pretty aggressive. They progress pretty rapidly over the matter of hours and days, and are really a substantial cause of blindness throughout the world. We tend to think of trauma and contact lens use as being the most common risk factors for developing these types of infections. And, lots of different types of bacteria can cause keratitis, and of course, viruses and protozoan and all that as well, and fungus. But amongst bacteria, probably the biggest players are Staph aureus on the gram-positive side and Pseudomonas aeruginosa on the gram-negative side. And so, typically when we have a patient who comes in, we got to figure out what is the bug that's causing this, because sometimes we don't even know, is it bacterial, is it fungal? We don't even know the kind of species or kind of general species that we're dealing with. So the typical approach is to do a corneal scrape. We were originally using Kimura spatulas, now being replaced by e-swabs, but we take a sample from the cornea and we send it off to the microbiology lab. And for those who have done that process, we know that the success rate, meaning getting a positive result of some kind back from the micro lab, can be a bit hit or miss, and sort of nationally, probably around 50%. So if you're in the scenario where you get a swab and you don't get a result back and things aren't going well with the patient, you certainly could ratchet up your ability to diagnose a patient by doing a corneal biopsy. So taking an actual piece of tissue and sending that off. And that often leads to a more accurate diagnosis, although there are some inherent risks of taking a piece of tissue out of a cornea that can be really hot or even actively melting. And then we also use our sort of clinical acumen to figure out what is the causative agent. Typically, we use that in the sense of trying to distinguish between, let's say, an acanthamoeba infection or a fungal versus bacterial. In bacterial infections themselves, there are some signs that may point you towards, a Pseudomonas infection versus staph, but in general, it can be pretty difficult just by the look of it to really know what we're dealing with. And then, aside from getting the diagnosis, then patients often want to know, what's the outcome going to be? Am I going to lose my vision? Am I going to go blind? And to kind of figure out what the potential prognosis is for patients, we use a couple of different factors. We obviously use the clinical findings. How big is the ulcer? Do they have a lot of anterior chamber reaction, like a hypopyon? Are they actively melting? We think about patient factors. So what is their underlying comorbidities, both from a general health standpoint as well as an ocular standpoint, and social determinants? How are they able to get the drops? Are they able to get the drops in? And then we might think a little bit about organism factors, whether it, again, if it's a bacterial fungal infection, might kind of change how we think about how this patient is going to do. And even on the bacterial side, with Staph aureus, for example, sometimes we get that clinical micro result back that it's MRSA or methicillin resistant Staph aureus. And sometimes that can ring a bell like, hey, this might be a bit more of an aggressive infection than we'd otherwise dealing with. But I would argue that even with kind of all those tools to diagnose our patients and then sort of the factors we use to provide a prognosis, a lot of times it's uncertain and it's an empiric approach. Certainly while we're waiting for results back from micro, we kind of throw the kitchen sink at patients, especially if it's a pretty severe ulcer. So that can involve all of these different things, such as fortified antibiotics. Those are our compounded medicines that are made for our patients. And we may consider some of these other agents as well, depending on the clinical picture or the history. And these patients need a lot of treatment and they need a lot of close follow-up. So I guess the question is, how can we do better? How can we do better in terms of diagnosing our patients and then providing them a prognosis? And what I'm going to argue over the next few minutes is that how can we leverage whole genome sequencing of our bacteria to not only help us kind of narrow down the diagnosis in a much more granular way, but can we use the whole genome sequencing to understand a little bit about the epidemiology of bacterial keratitis and to understand, are there certain features or genetic features of bacteria that can help inform prognosis? So in order to kind of go down that line of questioning, I needed a model organism to start with. And so I chose Staph aureus. Again, it's one of the most common causes of keratitis. It's a gram-positive organism, and it's pretty ubiquitous, right? It's implicated in many different types of infections throughout the body. And 30% of us, carry Staph aureus in our nose or other mucous membranes as sort of asymptomatic carriage. And it's interesting too to think about because it's a pretty diverse bacteria. And what I mean by that is calling Staph aureus just Staph aureus is a little bit like calling all of us Homo sapiens, which is really true. We're all human beings, but clearly there are many genetic differences amongst us as humans, and the same is true for bacteria. And so Staph aureus is not just Staph aureus, just Staph aureus. There are many different kind of subtypes and lineages of Staph aureus. And I'll delve into that in the coming slides. So again, the key goal for me was to see if I could leverage whole genome sequencing of bacterial isolates, bacterial Staph aureus isolates, to understand if there are any genetic differences between the types of strains of Staph aureus that cause eye infections versus the Staph aureus that may cause other infections, like a blood infection or a soft tissue infection. Because again, the goal was really to, if I could identify key differences between those populations, and then maybe that's something we can leverage for understanding keratitis a little better and understanding how to treat our patients a little better. And so the two kind of areas I initially have been focusing on is just understanding the circulating lineages that causes eye infections. Are they the same strains, again, that cause other types of infections? And then delving a little deeper, are there specific types of virulence factors or that eye isolates, eye Staph aureus isolates produce that are different than other Staph aureus strains? Are there things that are being produced by those Staph aureus strains that infect the eye that are particular to the eye or cause particular damage to the eye? So, so the first step was to collect a lot of strains, which I did, what I've been doing over the past couple of years. Right now I have a bank of about 163 Staph aureus isolates that have been collected from the eye. And these are from all over the world. They're fairly contemporary from 2017 forward. And they are from cornea, mostly from cornea scrapes, although I do have some conjunctival swabs and some that have been sort of broadly categorized as eye swabs, which could mean cornea conj and possibly even endophthalmitis. But largely it's a cornea centric strain set. And all 163 of those isolates underwent whole genome sequencing. And I needed to create a sort of comparator data set, Staph aureus strains that did not cause eye disease or were at least isolated from non-eye infections. And that is my 116 non-ocular set there you see on the right. This set actually was curated from NCBI. So a lot of people have sequenced Staph aureus genomes. And so we delved into what was already published and culled out 116 fully annotated genomes, again, from non-eye sources. And the first kind of pass, what I wanted to do is just to look at the kind of lineages. What are the strain types that are causing eye infections and non-eye infections? And there are many different types or approaches that you can use to type strains. So one of the most common ones is called MLST. It's called multi-locus sequence type. It looks at a series of 7 housekeeping genes and looks for little SNPs or little polymorphisms in those housekeeping genes and groups strains together based on the pattern of kind of individual mutations. And this is the data that I'm showing you before. Don't worry about the numbers, they're sort of irrelevant, but just kind of shows you relative abundance of certain MLST types amongst my two strain sets. And in the eye, the ocular Staph aureus, the predominant circulating types were MLST 30, 8, and 5, and then a smattering of other ones around there. And then if you look at the non-ocular side, we see 8 again, we see 5, and then interestingly, no 30, but we see 239 as kind of the most common MLST type. And not to get into the too nitty gritty around how we analyze this data, but if you kind of take that 30,000 foot view, you know, there are some pretty broad similarities between eye and non-eye. And I think if you just stopped here and said, and just looked at the MLST analysis, you might say, you know, I think eye isolates are pretty similar to the, you know, Staph aureus that causes disease in other body, you know, other parts of the body. There's nothing really special about the ocular isolates here. There was a lot of overlap and a lot of similar typing in both strain sets. So I decided to kind of look a little deeper at something other than just kind of the generic strain typing, and that was to focus in on the virulence factors. So Staph aureus produces hundreds, at least 235 that I know of, virulence factors. These are things that the bacteria produce that wreak havoc in the human body, and they range everywhere from helping the bacteria adhere to host cells, to forming biofilms. Iron regulation or dysregulation are a big part of what enables bacteria to be successful in the host environment. Hemolytic toxins, immune modulators, superantigens, et cetera, et cetera. And the list goes on. This is by no means comprehensive. And so I started to think about, like, could we look at our eye isolates and our non-eye isolates and compare virulence factors? Are the same type of virulence factors found in each group, or are they different? And so what we did was sort of define what I would call a virulence factor signature. This is a heat map, and just to walk you through it just briefly, along the y-axis here is a list of 235 individual virulence factors, and the color coding there puts them in functional groups. So for example, like those adherence virulence factors, or there's hemolytic toxins, et cetera. And then across the top, across kind of the top x-axis, is all of our isolates, both eye and non-eye isolates. You can tell which one are eye or non-eye by the blue sort of gray bar there. Eye is blue and non-eye is dark gray. And then there's some other distinguishing features we looked at. We don't have to get too much into the detail, but we looked at geographic origin, you know, exact isolates from North America versus Europe, et cetera. We looked at the status, whether they are MRSA isolates, methicillin resistant isolates, or methicillin sensitive. And what you can see is that we actually were able to divide all of our isolates into 4 big groups. That's if you look at the very first bar across the x-axis there, that's kind of that brown, pink, teal, purple. And, you know, not like, again, just taking that 30,000 foot view, you can sort of see, if you like kind of back up and blur your eyes, that in each one of those kind of 4 groups, we saw similar kind of patterns of distribution of virulence factors. So did look like there were groups of strains that looked like they had certain virulence factors, which would be in blue, and were missing other virulence factors, and that sort of changed. And so that was really interesting, because it really kind of brought home the point that we have all these isolates, right? We've got hundreds of isolates here, and they don't all have the same virulence factors. They have actually a kind of a range of virulence factors, and there's differences between them. And so we asked a question: what if we just separated the eye versus the non-eye, and are there any statistical differences there? And what was so fascinating to me and really interesting is what we found is that a group of enterotoxins, and I'll explain what enterotoxins are in a minute for those who are unfamiliar, but we found a group of virulence factors called enterotoxins that were statistically enriched amongst our eye isolates versus our non-eye isolates. So if you look here, we've got a list of about 12 of those there. They were found in about 60% of our eye isolates, where they were only in about 30% of non-eye isolates. And then you have a few at the bottom that were actually not found at all in our non-eyes, but were found in about 10 to 13% of our eye isolates. The dark gray line, the dark black line there underneath actually shows 4 genes that were pulled out that were enriched in our non-ocular isolates and not found as frequently in amongst our ocular isolates. And we're not really going to delve into that so much. I'm going to focus on sort of the enterotoxins. So what are enterotoxins? For those of you who are unfamiliar with them, they are known as superantigens or immune modulators. They are responsible for massive non-specific T cell activation, and most people are familiar with them in the setting of like a toxic shock syndrome or food poisoning. But the role in keratitis is really unknown, and really finding this genetic data that enterotoxins seem to be enriched in our eye isolates sort of kind of brought up the question, you know, is there some sort of competitive advantage of isolates with enterotoxins in the eye? Is that something that kind of gives isolates specific or special virulence in the eye that we haven't previously understood? And so the next kind of step for me was to sort of validate this genetic data, right? Just having the gene doesn't mean it's expressed or it's doing anything. And so just to show you a little data along those lines, what we looked at were, we pulled out 2 clinical isolates, and we've since tested this on many more isolates since then, but I'll show you 2 here. Strain 104 does not have any enterotoxins. Strain 70 does have a lot of enterotoxins. And we looked at, for example, in the panel on the left, the ability to cause corneal epithelial cell death. So we grow our bacteria, we actually spin it down, so we pellet them out, and we take the supernatant, which would include anything the bacteria is secreting, and then we sprinkle that onto our corneal epithelial cells and then see what happens. And what we saw pretty quickly that over time, the strains that produce enterotoxins were much more toxic to corneal epithelial cells than the strains that do not produce enterotoxins. And on the right-hand panel, we were interested, like, okay, that's interesting. That's a, you know, an in vitro model, and maybe not altogether that unsurprising given what we know about enterotoxins. But we wanted to take a look at what happened in the mouse in an actual in vivo model of keratitis. And so we took mice and we infected them either with a strain that produced enterotoxins, again, that 70 strain, or a strain that does not produce enterotoxins, which is 104. And I'm not showing you this data here, but when we first did the experiment, it was sort of interesting because it looked as though the enterotoxin producing strain wasn't very virulent. When we just looked at the eyes, they didn't look that infected. And so we kind of were, I was a little bummed out about that. But then when we looked at the bacterial burden, we saw that the strain that that had the enterotoxins really produced a much higher bacterial burden than the one that did not. So it was kind of this interesting picture of clinically, the cornea didn't look too bad, but there was a ton of bacteria there, more than we expected. And then when we looked at those homogenates for kind of a basic panel of cytokines to kind of gauge what the host response was, what we found was that in the strains that produced enterotoxins, even though there was a lot of bacteria around, it was sort of a muted immune response. You can see IL-6, 12, 13, TNF-alpha. And those light gray bars, that's our strain that produces enterotoxins. So it almost dampened the immune response compared to our non-enterotoxin producing strain there in black, which produced much higher levels of 6, 12, and 13 and TNF-alpha. TGF-beta I show there on the side is a slightly different result there. Typically what a cytokine that we might associate with kind of healing or kind of towards the end of infection. But anyway, not to go too far into that, but just to focus on sort of those first 4 there. So it sort of led us to this hypothesis that maybe the enterotoxins are modulating the immune response in the cornea in order to promote bacterial survival. So why I kind of brought you through that is sort of how kind of the long game, or how do I see this work being sort of relevant. What I see down the road in our lifetime is maybe the ability to, when we do our corneal scrapings, instead of trying to grow it on a petri dish, but to take that and do whole genome sequencing. And certainly genome sequencing is becoming quite rapid and pretty affordable. And so I do think that's probably the future of clinical microbiology to some extent. And so the benefits of that is we can get a species, we can know that it's Staph aureus, but we can also gain some insight into the lineage. What strain type is causing this, which can also feed into our understanding of the epidemiology of this disease. And then maybe we can use that genome sequencing to get a readout of specific genetic determinants that might portend a particular prognosis or might suggest that this is going to be a more aggressive infection or not, such as this is an enterotoxin producing strain or not. And with that information, my hope is that we can get better at understanding the prognosis, but also get new targets to develop specific therapies to treat these infections. So right now, so this is kind of some early work that we're doing in the lab. So we've got a lot of work to still do. We're growing our strain collection as fast as we can. We're looking at other types of genetic determinants that may be important in ocular infections. And of course, the long range goal of developing new therapeutics based on those targets. And so with that, I'll sort of wrap up. I'd just like to acknowledge some of the folks that helped me do the work, particularly the current postdoc in the lab, Will Johnson. My mentor on my K08 award is Paul Dunman in the Department of Microbiology, and I've listed my research support there. With that, thank you very much.
Dr. Prithvi Mruthyunjaya is an associate professor of ophthalmology at Stanford University School of Medicine and Byers Eye Institute. He is a retina specialist, director of the Ocular Oncology Service, and director of the Vitreoretinal Fellowship. He began his training in upstate New York, graduating from accelerated BS-MD program at Rensselaer Polytechnic Institute and Albany Medical College. After completing his medical internship at the University of Rochester, he did his ophthalmology residency at Duke, where he was chief resident. He stayed at Duke, completing a research fellowship in vitreoretinal disease and a clinical fellowship in vitreoretinal surgery. He then completed a clinical fellowship in ocular oncology at Moorfields Eye Hospital. He returned to the US and joined the faculty of Duke, reaching the rank of associate professor with tenure before accepting his current appointment at Stanford. He's authored or co-authored more than 125 peer-reviewed journal articles, has participated in over 30 industry-sponsored or NIH-sponsored clinical trials related to posterior segment disease and cancers of the retina. He's delivered invited lectures across the globe and has precepted more than 40 clinical and research fellows in vitreoretinal disease. He's a HEAD ophthalmic fellow and was named by Ocular Surgery News as one of the top 150 retinal specialists in the world. We would like to thank Dr. Mruthyunjaya for joining us this morning to deliver his lecture, Current Management of Choroidal Melanoma.
Good morning. Thank you, Dr. Plotnik, for that very kind introduction. Let me see if I can get my slides up for you. Are you able to see those?
Perfect.
Yes.
Great, thanks. Whoa. Yes, we're good?
Good.
Okay, thank you. Thank you for this kind opportunity to speak at the 65th Rochester Ophthalmology Conference. Here are my disclosures, none of which are pertinent. So a little background, I'm a Rochester boy. So I grew up in Brighton, and this is Brighton High School, where I have probably some infamous and notorious stories that I could share with you when we meet in person. And other than being in the shadow of Don and Bob's, which was always just down the street, I was always reminded to be in the shadow of this great university. And I had a great opportunity as a high school student, as a senior who was interested in medicine, to spend some time as a research intern at the University of Rochester. And that's where I met some of my very first mentors who have been inspirational and guidance for me through the years. This is Dr. Manuel Del Saro, who is a professor of neuroanatomy, and his laboratory partner and a wife, the late Coco Del Saro, who really took me under their wings at a very young age, very impressionable age, and taught me so much. It was during that time when I was in high school, I met a very prodigious, prodigal MD PhD student who had just started his work in the lab with Dr. Del Saro, David DiLoretto. So David and I have had our paths cross, over the decades now, probably over 30 years, David. And it's a great pleasure to see him rise through the ranks and now leading this great department in Rochester. So I am an ocular oncologist. So I take care of the comprehensive needs of patients that have cancerous, precancerous, or simulating conditions in and around the eye. But we also think about the impact of treatments of the systemic cancers on the eyes themselves. And what I love about it is that though being a retina specialist, it really spans all of the specialties in ophthalmology, and I get to work with so many colleagues from the front of the eye to the back, as well as our medical oncology friends. We know that cancer is a global problem. And many of us, if not all of us, either know friends or family that have unfortunately been affected by it. In 2020, we know that in the United States, there are nearly 20 million new cases of cancer, and about half of those, half of that number resulted in deaths in the year 2020. So we are far from a situation where cancer is a word of the past. But one of the encouraging sights is that if we look over the decades, the work that's being done to improve therapies, improve screening, improve detection has now started to shift the curve a little bit. So now over the past decade, we have started to see causes of death from cancer go down over time. And I think that's very encouraging. But it takes a multidisciplinary outlook. And one of the cancers that we as eye care specialists have a very keen opportunity not only to diagnose, but to manage the treatment of is what we'll talk about today, which is ocular melanoma. So what we'll cover today is what is the difference between a nevus and a melanoma, what is the current state of genetic testing for ocular melanomas and prognosis, and a little touch on some of the new therapies that we are being able to offer to our patients. So uveal melanoma is the most common primary intraocular malignancy that we find in adults. There are about 6 cases per million in the United States, so it's about 2,400 new cases per year in our country. Men are more likely to be affected than women, and this is a condition of age, so older patients more likely. And we can see that uveal melanoma may involve any layer of the uveal tract, so the choroid most commonly, but the ciliary body and the iris can also be areas of involvement. And people always ask, what are risk factors? And in uveal melanoma, there really aren't any clear genetic risk factors for patients. There's not really a strong family history, except in rare genetic disorders. But it all starts with a choroidal nevus. These are majority seen in the posterior pole. Only minimal nevi are symptomatic when they're at presentation, and only less than 10% result in vision loss. And these tend to be relatively small, about 5 millimeters in base and maybe up to about 1.5 millimeters in thickness. If we look across the world studies in terms of the prevalence of a choroidal nevus, in the United States and in Australia, which has a very high sun exposure and problem with systemic melanoma, it's about 4.7 to 6.5% prevalence. But if you look in Asian countries where large scale studies have been also done looking at prevalence, much lower. So we think of kind of Caucasian skin tone, lighter skin as being a potential risk factor, if not an association that we kind of take into account. The diagnosis of a benign choroidal nevus kind of falls into a couple of different categories. Generally, they're flat to maybe minimally elevated, about 2 millimeters. We tend not to see any subretinal fluid. Often the signs of chronicity of these will be the presence of drusen on the surface, and we don't see orange pigment, which is lipofuscin. And this would all give us confidence that the lesion that we're looking at is a benign lesion. But there's obviously variations, amelanotic lesions, ones that are very close to the optic nerve, peripapillary, and these halo nevi that have a depigmented circular border around the outside and then a more pigmented central core. When we look at the spectrum of these melanocytic choroidal lesions, on the very low risk end are just freckles, so just very small areas of patchy melanocytosis in the choroid, then the formed choroidal nevus that we discussed, and then the malignant melanomas, which we'll discuss, which are pretty clear in terms of their presentation. But that also gives us a large area of this indeterminate choroidal lesion, which have some features that are nevus-like and some that are melanoma-like. And those are the ones that we spend the most time hashing out in clinic, trying to figure out, is this a melanoma or is this a nevus, and trying to direct treatment for it. There are clinical features that have been propagated as being important to determine the rate or prediction of growth of a nevus. So looking at the thickness, the presence of subretinal fluid, symptoms, the presence of orange pigmentation, and also some of the characteristics of the lesion themselves. And ultimately, these risk factors put into a model tells us that having multiple risk factors increases the risk of growth. And that risk of growth might portend that this lesion may have metastatic potential or malignant potential. Here's a patient who I saw in 2017 that had a darkly pigmented lesion in the fundus just inside the supratemporal arcade and encroaching on the fovea. Had some lipofuscin, abundant fluid. This patient elected to have us observe. And as we can see, over the course of about 1.5 to 2 years, we can start to see the lesion has starting to grow. And then we're more concerned now that this lesion may have malignant potential. But not all growth of a nevus is malignant. So a choroidal nevus can have physiologic growth, but it's the velocity of growth. How quickly is it growing over time that makes us more or less concerned. Here's a patient that had a lesion inferior to the optic nerve. The patient was observed, but then lost to observation and then returns with this, a giant melanoma with exudative retinal detachment. So serial follow-up is critical in these patients, as sometimes a very benign appearing lesion seen once, if not followed, could actually change quite dramatically. And the diagnosis of uveal melanoma is clinical. Rarely do we perform diagnostic biopsies to make the diagnosis. Often it's based on clinical features and imaging, and often it's frequently found on a routine eye exam. And nothing beats a good clinical exam. So any kind of imaging modality that we talk about, still the clinician is the one that's going to make that diagnosis. Here's an example. This is a 62-year-old pediatrician who went for a routine eye exam and had no visual complaints. And this is his ultra-wide field imaging that was done at the clinical visit. So that looks pretty normal to me, but it turns out that his eye doctor ended up doing a good peripheral exam and found that he actually has a peripheral uveal ciliary body melanoma. And this wasn't detected on the clinical photos that would have been taken during screening. So it shows the importance of good peripheral examination techniques that we all have and all use and have to consider with these patients. A small uveal melanoma has a couple of clinical features that we should look out for. So the presence of subretinal fluid, a height usually greater than about 2 to 2.5 millimeters, the presence of lipofuscin pigment, which is kind of orange colored pigmentation. And large melanomas tend to be very easy to spot. So they have low internal reflectivity and ultrasound. Often they can have large exudative retinal detachments and the presence of subretinal hemorrhage in some cases. So this would be a large melanoma. We use ultrasound to help us with the diagnosis. It can help us with morphology and with surgical planning. These tend to have low internal reflectivity, and you can see the ultrasound correlates quite closely with the actual clinical picture. And it is the gold standard to assess tumor height on all of these tumors. So these are done quite regularly in our clinic. Other clinical signs of advanced melanoma, sometimes we can see sentinel conjunctival vessels, unilateral glaucoma, there can be lens displacement, and exudative detachment, as this upper photo here shows, with the retina plastered against the back of the crystalline lens. In some cases, signs of extraocular extension. The current state of uveal melanoma care in terms of treatments for small tumors is usually reserved for careful observation, and in some cases, laser therapy or radiation. Median tumors, we tend to favor doing radiation therapy, and large tumors, if we can spare the eye safely, we will irradiate them. If not, they will be removed with enucleation. The two effective treatments for uveal melanoma, one is enucleation. So you have a 100% chance of controlling the tumor in the eye by removing the eye. Radiation therapy gives us also very good chances of controlling the tumor, either with proton beam radiation, which is an external source of radiation, or plaque brachytherapy, which is what we favor, in which radiation is placed directly on the back of the eye. And we call this episcleral plaque brachytherapy, where we have this tumor that's within the eye itself. We take them to the operating room and we place a gold-coated disc that has radiation seeds impregnated within it. This is placed on the outside of the eye, and the patient has this in place for about 5 to 6 days. And then upon removal of the plaque, the tumor we watch shrink over time. Here's a patient that has a fairly large, medium-sized melanoma that overhangs the optic nerve. You can't really even see the optic nerve. She had undergone radiation therapy. And now as that plaque is placed and allowed to dwell for 6 days, now we can see her tumor regress back. We can see the optic nerve. She's retained really good vision now over 2 years at 20/25, but we worry about side effects of the radiation over time. Enucleation gives us excellent local tumor control, but we lose the eye and no vision. But again, if we're trying to prioritize the patient's overall general health, sometimes it's necessary in these very large tumors. We recently looked at a trend using a large cancer database, and in over 4,500 patients, what we found is over a decade's time, there's been an increase in the uptake of radiation therapy. So a 14% rise in the use of radiation to treat uveal melanoma with a concordant decline in enucleation rate. So it shows that we're doing more to try to save eyes than to remove them, and I think that's a positive trend. When we look at advances in ocular melanoma, we want to improve treatment options for our patients. We'll look at advanced genetic testing and then how we are now tackling metastatic disease. So there are three main ways that we're improving globe sparing or non-enucleation techniques. So the first is with precision radiation planning. So we're using very advanced CT and MRI guided systems to plan the radiation. The second is we're using choroidal tumor biopsy to be able to obtain genetic information that helps guide subsequent therapy for our patients. And we're being very aggressive with the treatment of radiation retinopathy prophylactically and actively with the use of anti-VEGF and steroid medications. We always screen for metastatic disease because the truth is about 25 to 50% of our patients develop metastasis with their millimeter size ocular melanomas. And most commonly, this goes to the liver. We usually use modalities like CT, PET, or MRI in order to screen vital organs. And we've stopped using liver functions testing, which before used to be used as this lacks sensitivity. The reason why we worry about ocular melanoma is this concept of micrometastatic disease. So at the time the eye tumor is diagnosed, we feel that it is possible that 1 or 2 cells may have already left the eye and are floating around in the body, but just haven't made it to the liver. So even though we find the ocular tumor and we treat it successfully, patients can still develop metastases down the line. And that's because the tumor has already left the eye, we just can't detect it. And that's the frustration and the challenge in uveal melanoma treatment. We can try to treat the patient with adjuvant therapies along the way, but we still haven't found the perfect treatments up front. And ultimately, when the liver metastases are found, we have to direct our treatment to this, but already in the metastatic setting. So estimating metastatic risk is important. If we can figure out who's at risk, we may be able to screen them better, more effectively, and think about treatments to help them. So clinical features, what we just talked about, have been used to stratify risk. Histopathologic features, so that means the eye is removed, large tumor, you can figure out some risk factors there. But now in the world of genetic testing, chromosomal alterations have been identified to see changes in chromosomes 1, 6, 8, and 3. And we'll talk about kind of the state of the art, which is gene expression profile testing that helps to define various subclasses of these melanomas. In order to obtain genetic information, we have to actually sample the primary tumor. So there's an increasing use of biopsies in uveal melanoma because of the uptake in melanoma genetic testing. Biopsies taken at the time of treatment to determine prognosis, but also in some cases to confirm this diagnosis. So here we'll show you kind of 2 different biopsy techniques. On the right of your screen is a transvitreal technique, and on the left is a transscleral technique. So with the transvitreal on the right, we're using either a needle to go into the tumor itself. Here we use a vitreoretinal setup using a endo-illuminating light pipe. Once we're in the tumor, we can use a suction force gun to be able to obtain the tumor tissue, and then we withdraw with minimal bleeding in the eye. On the left, the transscleral technique allows us to make a scleral pocket on the outside of the tumor itself. Here we enter in with a needle, and then we can remove the tumor tissue, and we can see in the hub of the needle these dark little fragments of tissue, and all we need are just a few cells to make the genetic calls on these patients. Another technique that we've been interested in is the use of pars plana vitrectomy instrumentation. So this is a 3.4 millimeter tumor, and we set up a 27 gauge 3-port vitrectomy setup. And instead of using a needle, we use the vitreous cutter to enter into the tumor. We engage the vitreous cutter to take little chomps of the tumor itself, and we aspirate them into the to the line of the cutting device. We carefully go into the tumor and we carefully come out. Sometimes the retina sticks to the edge of the opening of the cutter, so we carefully manipulate our way around it. You can see there's really minimal bleeding, sometimes a little bit, but it's usually self-contained. We don't do a full vitrectomy. And here we can see within the tubing the clearly visualized cells that are seen within the tumor. And we've reported on this and shown that this is an effective and safe treatment with minimal risk of tumor disruption and no increased risk of metastasis. So if we look at the genetic testing that's available for our patients, there are several. So chromosomal-based next-generation sequencing and gene expression profile testing. So the gene expression profile uses a CLIA-certified lab. The biopsy specimen is sent in a transport buffer, and then using bioinformatic cut points, only about 8 cells are required in order to tell if a tumor has a specific signature for uveal melanoma. And what we find is that the gene expression profile divides uveal melanoma into 3 distinct molecular clusters. One is called class 1A, which is the lowest risk of metastasis, about 2%. Class 1B, an intermediate rate, about 12%. And then class 2, which has a high rate of metastasis, or 70%. So now we can take a patient and then now divide them into a risk category, which can be rather important for them. This has been validated prospectively through the work of Dr. Bill Harbour, and we were involved in the original validation studies. And now this has moved on to a second generation of collaborative efforts to try to better understand the genetics of uveal melanoma. A really important outcome is now that these risk stratifications can now be used to divide how patients are screened by medical oncologists. So based on clinical features and gene expression profile, we tell patients whether they need yearly screenings every 6 months or every 4 months, and I think that's important. Looking at some new experimental treatments, we are looking at new ways to improve non-radiation treatments for uveal melanoma. Because the problem is when you have a very small melanoma in the macula, when you treat them with radiation, it's a high risk for radiation retinopathy and vision loss. So the AU11 is a therapeutic that uses a molecule that's directed into the vitreous. This attacks and attaches itself to the choroidal tumor itself. And using a photodynamic therapy type light, it is placed onto the surface of the tumor and it activates T-cell mediated cell killing. And in this early phase 1, phase 2 study, what we can see on the dotted line is the projected growth of these tumors that were followed into the study itself. And the blue line shows their actual growth. So the treatment has helped to arrest the progressive growth, and it had about an 88% tumor control rate in the early phase studies. Now, the second phases of the study are using both not only an intravitreal, but also a suprachoroidal delivery system, which I think will also be interesting. And finally, uveal melanoma metastasis still has no proven treatment. And many treatments that have been used in cutaneous or skin melanoma have been redirected to try to treat ocular melanoma, but it hasn't been as successful, only about an 18 to 20% success rate in controlling metastatic uveal melanoma. This is an interesting target called TEBENTAFUSP, which is a bispecific T-cell redirection therapy. So it's a molecule that has kind of 2 arms to it, one that attaches to the cancer cell, but the other one that recruits your own immune system or T cells to come and then kill the cancer cell. And in doing so, this can allow your own body's immune system to attack the melanoma. And in early phase 1 studies, this patient treatment showed that there was a progression-free survival of 66%, which is really impressive in that standard of care treatments are only about 20% effective in most cases. And a recent phase 3 study of over 370 patients showed that the overall survival was 78% compared to standard of care, which was 58%. So this is actually an important new therapeutic that may be available. And there are many ongoing clinical trials. So as we see our patients with metastatic melanoma, we work with our medical oncology colleagues to get our patients into these clinical trials to learn more. So I'll end by saying it's a new era in uveal melanoma collaboration between eye specialists, medical oncologists, patients, biopharma, and ocular oncologists as well. So there'll be much more for us to learn and hear about in the future. Thank you again for this opportunity to share this information and look forward to questions.
We're now going to hear from Dr. Mruthyunjaya, OCT tips for ocular tumor diagnostic and management issues.
Thank you very much. Let me pull up those slides. Is that looking good?
Looking good.
All right, thank you. So we'll kind of continue the theme of OCT and diagnostics. That was a great talk, by the way, that we just heard on all the upcoming therapeutics. It's super exciting. We'll talk a little bit about OCT today and how we in a tumor clinic use OCT kind of as a indispensable tool, just like we all do in everyday practice. But we'll talk a little bit about both posterior segment, but also anterior segment OCT, which may have some new applications for us. None of my disclosures are pertinent here, but I wanted to talk about another Rochester boy who has ties to your department. So as mentioned, I had a great time at the Duke Eye Center in Durham, North Carolina, where I did my residency and started my faculty career. In the early 2000s, a childhood friend and a very close friend, Rajiv Ramchandran, came to be a resident with us. So not only did I get to boss him around as I did when I was growing up, but he flourished into a fantastic resident and came back to Rochester to do his retina fellowship and has since joined the faculty. Rajiv is a upstanding member of his community in Rochester and has been doing some really innovative work in tele-ophthalmology and diabetic screening, which we heard about yesterday. A good friend and recently married, and someone who I'm very proud of as one of my former students, but more importantly as someone who I look as a younger brother. So a little shout out to Rajiv. So we'll talk about the role of OCT in the diagnosis of ocular tumors. How do we generally diagnose ocular tumors? Why do we use it? And how do we use it in ocular oncology? And let's maybe go over some examples in both anterior segment and posterior segment tumors. So in my oncology clinic, new patients really get imaged extensively. So not only with SLR fundus photography, ultra wide field color photos, fluorescein angiography, and fundus autofluorescence are indispensable. We use enhanced depth imaging OCT as well as ultrasound to give us three-dimensional cross-sectional information about these various tumors. So lots of imaging going on. When we think about multimodal imaging in ocular oncology, there are several imaging modalities that we go through in trying to come up with a diagnosis and to follow our patients. So the most important is probably fundus photography. So this gives us very important information about the borders of the lesion, characteristics of it, but most importantly, documentation. So if you do nothing else, if you don't do an OCT, always take a photograph because that helps to give a context of how the lesion looked at that particular time, and to make sure if the patient, has a lapse in their follow-up, whether the lesion that you're seeing now would have changed in the future. So the tip is always try to take a picture. We use ultrasound to determine the thickness and internal reflectivity of a lesion, and is still, as mentioned, the gold standard to assess tumor height and internal characteristics. Fundus autofluorescence has increasing importance to confirm the presence of pigments on the surface of a tumor, such as lipofuscin, but also gives us a sense of the health of the retinal pigment epithelium overlying these choroidal tumors. That might tell us if a lesion is more chronic or acute. And fluorescein angiography is really important. It tells us about vascular patterns within tumor, response to therapy, and radiation complications that can occur in this example. So it's multimodal tumor imaging that we use in composite, not just any one modality, but taking them all together to try to then put together a photo of the patient in multiple dimensions with various informations that then lead to a diagnosis. But OCT is probably one of the techniques that we use ubiquitously from the front of the eye to the back of the eye. So we'll talk about anterior segment and posterior segment OCT in ocular tumors. And the tips that I want to go over with anterior segment tumors is, number one, determine the level of involvement. Is it epithelial, subepithelial, or obviously in the iris? And we can also use this to monitor treatment response. So in order to understand how to use anterior segment OCT, we need to understand what the normal conjunctival epithelium looks like on OCT. So basically, this is an anterior segment OCT of just the conjunctiva overlying the sclera. In this boxed area here, we can see kind of two areas. The yellow arrow is the subepithelial portion of the conjunctiva, and the lighter gray area shown with the blue arrow is the conjunctival epithelium. And that epithelium junction is what's important in diagnosing disease. We can use anterior segment OCT or ultrasound biomicroscopy, or UBM, to help diagnose these lesions. And there's different acoustic features that we learn with UBM that we don't get with OCT. And OCT does have some issues with looking at pigmented lesions because of shadowing that occurs from that top layer that prevents us from sometimes seeing the entire lesion down below. So for intraocular lesions, then anterior segment OCT may not be as good as UBM, but it just depends on the condition. So we tend to image larger lesions with both. So if we look at benign conjunctival lesions, these are ones that we see all the time that can sometimes be confusing whether they represent a malignancy or not. We'll look at pinguecula, pterygia, and iris cysts. So pinguecula, we know, are actinic damage from sun exposure. We can see these as yellow gelatinous lesions, but sometimes they can have a leukoplakic or whitish appearance to it that is making us a little concerned that this could be a neoplastic proliferation. So this is an OCT of the same pinguecula that we see on the clinical exam. And what we notice is that there is an intact overlying epithelium. So that gray epithelium continues whole, but there's a subepithelial nodular hyperreflectivity, and that is the pinguecula itself. So a subepithelial correlation rather than an epithelial disease. Here's a pterygia, where we can see this fibrovascular growth onto the surface of the corneal epithelium. And taking an anterior segment OCT, we notice the features of the normal epithelium on the cornea, but this hyperreflective subepithelial component that sits on top of the corneal stroma. So we can see clearly that this pterygia is not invading the epithelium, but it's kind of growing underneath the epithelium onto the surface of the stroma. Here in cross-section, we can again see the clear overlying epithelium and the hyperreflective stromal lesion, which is the pterygium. A conjunctival nevus is a benign melanocytic circumscribed lesion, usually influenced by hormonal changes in young children and in women. It can have minimal thickening, and often we see cysts that usually indicate a more chronic appearance. And here's an example of a NEVUS, where we see these solid structures, but also these hollow structures, which are the cysts that occur within it. Here's an example of an amelanotic nevus that has some pigmentation, but could be confused for a surface squamous neoplasia. And when we use the anterior segment OCT, we can see the full thickness involvement of the epithelium and the subepithelial locations in these large cysts. And those cysts are usually helpful to help us define a benign process. This is a patient who comes in with a elevation in the peripheral iris. The iris itself looks normal, but it's localized shallowing that we see on slit lamp examination. And here on the right is the ultrasound biomicroscopy image, but also on the left is the anterior segment OCT that shows the smooth elevation of the iris and the iris pigment epithelium. And this is an example of a pigment epithelial cyst. So there's no solid tumor, but instead a cystic tumor. And this is that same patient that we saw with the pigment epithelial cyst. So ocular surface squamous neoplasia is essentially a malignant eye tumor process that can go from conjunctival intraepithelial neoplasia, which is a pre-malignant process, all the way over to invasive squamous cell carcinoma. Young men are usually more likely to develop this, and sun exposure plays a role. And it gives us a chance to treat these patients very early so they don't evolve into squamous cell carcinoma. So on clinical exam, we can see these kind of gelatinous appearance lesions, usually at the limbus, sometimes confused with a pinguecula, but this looks a little bigger than your typical pinguecula. Usually they're unilateral, elevated, have variable shapes, sometimes feeder vessels. They tend to be gray, sometimes red in appearance. The key on OCT is to find the abrupt transition between normal and abnormal surface epithelium. So as we cut across the lesion, and then this is an example of the ultrasound biomicroscope image, which again, you can see it's elevated, but it's hard to tell any more detail because of the resolution. But look what we find on OCT. There's a clear area of a junction between what on the left is normal light gray epithelium to hyper-reflective bright white epithelium, which is the lesion itself that is elevated. So this abrupt epithelial transition helps us to define what is the OSSN component over here versus the normal epithelium that abruptly transitions. So that's the key, the abrupt transition. Here's another example from a paper by Carol Karp, where we can see abnormal central hyperreflectivity, but a normal epithelium more towards the right. Now, a pinguecula, as I pointed out, has normal epithelium. So here's an OSSN lesion with abrupt transition that we can see normal to abnormal, and then a pinguecula that just shows the overlying normal epithelium and the hyperreflectivity in the subepithelial space. Here's an example of a case of a patient that has both a pinguecula and an OSSS lesion. So here's the pinguecula, here's the precancerous lesion. We cut through it with OCT, and we can see the precancerous lesion on the right with the red arrow and the subepithelial pinguecula on the left. So some patients can have two processes at once, and OCT may help us. Conjunctival lymphoma is another condition where we can see a salmon pink patch that can grow onto the surface of the epithelium. Often these patients may be asymptomatic and they just may have chronic irritation symptoms. The interesting component of a lymphoma is that the overlying epithelium is intact, but there's an expansion of the subepithelial space. So a conjunctival lymphoma keeps the epithelium, and that helps us surgically because in order to remove these or biopsy this, I don't have to do a full thickness conjunctival excision. I can just kind of fillet open the epithelium, scoop out that subepithelial mass, and then close the epithelium over it when we're done. Here's a couple other examples of some atypical lesions. This is a patient who had lower eyelid fullness. And when we lowered and inverted that lower lid, we can see this kind of cystic lesion that when we did UBM over the eyelid because of its location, we really couldn't appreciate that cyst. But anterior segment OCT shows a clear space of a tarsal conjunctival cyst. Here's a patient that has an irritated eyelid. Looks pretty clear when you look at it, but when she looks down, we can see this lesion, and then we avert the eyelid and we can see this papillomatous lesion that we can follow on OCT as well. And we can see this tarsal papillomatous lesion elevating the subepithelial space and involving some of the overlying epithelium as well. So we can move the OCT around to eyelids, fornices, in order to capture these diagnoses. And OCT can be used to monitor disease as well. Here's a young boy who had a conjunctival nevus here in 2015. You can see it's pretty diffuse. It kind of extends from 12 to 5 o'clock, not very elevated on OCT. You can see a single cyst. But as we follow him now over a 5-year period, we can see the lesion continues to increase and continues to pigment. Now it comes down to 6 o'clock and has a lesion over here as well. And you can see now the OCT shows significant thickening compared to where he was before. So this is an enlarging giant conjunctival nevus that we ultimately excised. And also it can help us show response to topical chemotherapy. Here's a large squamous cell lesion that we elected to treat with topical chemotherapy. You can see the shrinkage and reduction of the lesion now to a little leukoplakic plaque. This is what it looked like when we first started. And now when the lesion is essentially resolved, we just see a residual pinguecula, but the complete normalization of the overlying epithelium. And here's a patient that underwent surgery for a conjunctival lymphoma, had undergone radiation treatment, and then after radiation, we can see the restoration of the normal anatomy. And you can actually see the surgical incision site where we did the biopsy clearly identified on the OCT. So with anterior segment OCT, the tips is look for epithelial layer involvement. If it's present, then you think of a squamous neoplasia. If it's not, you think of a pinguecula or a lymphoma. And if it's full thickness involvement, we think of a choroidal nevus, or conjunctival nevus. So we'll move to the posterior segment. And the questions you have to ask when you look at a posterior segment tumor on OCT is that, number one, is there a retinal or is there a choroidal component? Number two, is there thickness to the lesion in the choroid? And then are there secondary effects on the overlying retina, subretinal fluid, RPE atrophy, drusen, or fluid collections? So when we look at the retina and where tumors can occur, we ask, where is the primary pathology? If it's in the vitreous, we think of lymphoma, vitritis. If it's in the retina, retinoblastoma, astrocytic hamartomas, combined hamartomas, lymphoma. If it's at the RPE level, most commonly we think of combined hamartomas or chirpies. And if it's in the choroid, we spend a lot of time trying to devise between a nevus, a melanoma, a choroidal metastasis, or even lymphoma. So the key to this is what we call enhanced depth imaging, which improves the imaging deeper into the retina and into the choroid. So essentially, when we do an OCT, we have a reference point that the computer selects to focus, which is at the retinal surface. If we then push that reference point a little bit further, that's called EDI, or enhanced depth imaging. So now the reference point is at the level of the RPE, and you can see in the same patient 2 images where the choroid is not as well identified, and now with EDI, we can see amazing details of the choroid. So enhanced depth imaging allows us to then assess thickness of these lesions underneath the retinal surface. If we can segment the junction of the choroid and the sclera, we can actually take very accurate measurements of these choroidal tumors. The limitations is that we usually can't go beyond 2.5 millimeters in thickness in order to get a full image, and there may be inconsistencies in imaging that posterior scleral border. Here we see with the choroidal nevus, the flat lesion, no subretinal fluid, and drusen, but sometimes it's hard to know if there's thickness or not that's important. So here's an example of a choroidal nevus. As we cut through, we can see compaction of the choriocapillaris. So underneath the layer of the RPE, there's kind of a bright white hyperreflective band, which is the choriocapillaris being kind of pushed up from the proliferating nevus cells. The OCT also identifies surface alterations on top of the lesion. So intraretinal fluid, subretinal fluid. It can help us to see if there's thickening, and we can also see subretinal deposits as well. Here's an example of a 60-year-old woman who is asymptomatic that has a nevus superior to the optic nerve. The question is this a nevus or is this a melanoma? When we do the OCT, we can see that the lesion is not elevated and not elevating the overlying retina. We can see the lesion in the choroid, but it looks pretty benign and flat. So this is a low suspicion nevus that we're going to follow. Another similar lesion in a 55-year-old man that shows an area of elevation now that lifts the overlying retina. So we can see that this has a greater substance to it. We can see some subretinal fluid now on the edge of the lesion. So this is a higher suspicion lesion that we'll follow much more closely. When we look at choroidal melanomas in terms of size and subretinal fluid and lipofuscin, all of these features become evident for us when we look at them on OCT. So a choroidal melanoma tends to have greater height than a nevus, tends to have subretinal fluid that we look for, and it has a smooth domed appearance, which we often don't appreciate with a benign nevus. Here's another lesion that we can see in the eye, a 45-year-old male who has acute vision loss in the right eye. He's healthy, he's a non-smoker, and has no history of malignancy. Here on multimodal imaging, we can see this large, mainly amelanotic lesion. And look at this OCT. It's like very irregular in the choroidal infiltration. There's subretinal fluid. So it doesn't look like that smooth domed appearance. And in fact, he had a choroidal metastasis from an undiagnosed small cell lung cancer nodule in his chest. And we know that the most common sites where that metastases come from in women are breast cancer and in men lung cancer. And this has been described on OCT as a lumpy, bumpy pattern of choroidal elevation and infiltration, often with excess subretinal fluid. This patient was seen and then started, once diagnosed, with oral targeted chemotherapy agents, and we can see the normalization or near normalization of the OCT and the ultrasound within 3 weeks by just taking a EGFR inhibitor. So the morphology also aids us in diagnosis. We see this smooth domed elevation of a choroidal lesion, which is a melanoma. We can see this lumpy, bumpy pattern of a lesion in the choroid, which is a choroidal metastasis. So there are some tumors that we can see in and under the retina. This is an example of an astrocytic hamartoma, a benign lesion seen in some systemic conditions. And we can see what looks like, instead of smooth round cysts, a retinal lesion. So it's not in the choroid, and it has a very moth-eaten appearance. So it's not these like clear cystic spaces, but it looks kind of moth-eaten and irregular. And that, combined with the fundus autofluorescence, helps us to make this diagnosis of an astrocytic hamartoma. Intraocular lymphoma can present in various manifestations, but OCT allows us to visualize all the layers that lymphomas can infiltrate. We can also see secondary effects on the retina, and it allows us to guide planning when we need to do full thickness chorioretinal biopsies. Here's a patient with blurry vision and gait instability. We can see the OCT cutting through the central macula with some subretinal deposits, hyperreflectivity, and subretinal fluid. But then when we go off axis and image some of these lesions, we can see these large areas of sub-RPE infiltration that are elevating the retina itself. And finally, some tumors can occur at the level of the retinal pigment epithelium. So this is a patient with a very circumscribed pigmented lesion, which is consistent with CHIRPY, a congenital hamartoma of the retinal pigment epithelium. Here we can see thickening of the RPE in the lesion region and also overlying thinning of the retina. And the autofluorescence shows dark hypoautofluorescence. So some examples that we've shown here of posterior tumor OCTs. So we want to first identify which layer the tumor is located, the thickness, whether it's flat or a thickened lesion within the choroid, and also the surface features like fluid and drusen that might help us to aid our diagnosis. And finally, the morphology distinguishes where the tumor might be located. And then thinking again of which layer the OCT is imaging and what tumors might be located in those locations. Once again, thank you for this kind opportunity to speak to you all today. Thank you.
Thank you very much, Dr. Mruthyunjaya. That was super helpful, and a lot of us will take that information to our clinics. We are now going to set up the panel. So we should, except for Dr. Kleinman, I think, are we all set? There we go. And Steve, are we going to take questions from the audience first?
Yeah, if the audience wants to raise their hand, there's a tool in the bottom bar. Otherwise, it looks like we have a couple of questions in the Q&A box.
I'll start with the Q&A box. Dr. Wozniak, talk about your strain collection. How is their vitality maintained? How are they stored, and how long can they remain vital?
Yeah, that's a good question, and really central to what I need to do. So bacteria are pretty fastidious. We actually grow them up in kind of liquid cultures, and then we can freeze them down in a -80 freezer, and they can survive in the -80, sort of in this frozen dormant state, sort of indefinitely. So we keep a master collection in our freezer, and when we need to study individual strains, we can just kind of dip a little stick into our stock and restreak it, and it will grow right back. So,
thank you. Another question for Dr. Mruthyunjaya is, have you considered injecting, checkpoint inhibitors directly into the tumor?
Good question. So the question comes with treating systemic melanoma or metastatic melanoma. There's a exciting class of new targeted agents called checkpoint inhibitors that basically try to alter how the immune system is used to attack the tumor itself. And it's been shown to be very effective in metastatic skin melanoma, which is very different from ocular melanoma. So the short answer is I don't believe there's a role right now for injecting them directly into the eye, because we find that these immune checkpoint inhibitors don't work as well in ocular melanoma as they do in skin melanomas. But I think it brings up a good point that trying to harness the power of the immune system may be an approach that is kind of regaining a lot of interest even in eye melanoma as well. So I don't know if injecting current off-the-shelf immune checkpoint inhibitors would be the answer, but I think finding ways to traffic the immune system towards the eye may be something that we should be looking forward to in the future.
Thank you. Directed towards Dr. Dana, any experience with cyclosporine A 2% in GVHD and oxervate for neurotrophic keratitis? And I would also add, we see a lot of these patients too. Maybe you could comment on the concentration of serum tears and whether they should be platelet rich or platelet poor.
Sure, I can begin. I see that there's another one also from Dr. DePaulis on Oyster's product. First of all, regarding cyclosporine 2%, just to give this some historic context, the use of topical cyclosporine really began with 2%, was even increased in a few conditions like AKC and VKC to 4% in some indications. And then due to studies done in the late 1990s by Allergan, in which, in full disclosure, I was also involved in those. We, 1% and 0.5, 0.1, and then eventually 0.05% was the dose that was selected. We do see more effect with the higher concentrations. The issue with cyclosporine really is tolerability. Tolerability is a problem with cyclosporine, both because of cyclosporine and also because of the formulation. They need to be emulsions, typically oil-based emulsions, because cyclosporine is not water soluble. And so it either has to go into another vehicle like cyclodextrin in Cequa, or it has to go in an oil-based emulsion. That causes problems. So we tend to see more tolerability issues with 2% cyclosporine than 0.05% cyclosporine, but we do get more bang for the, per drop from an anti-inflammatory effect. And we have used it in select patients with GVHD and other types of severe ocular surface disease. In regard to recombinant human NGF or nerve growth factor, Synergermin or oxervate. Yes, we have a lot of experience. In full disclosure, I was a consultant to Dompe, and I was the consultant for the FDA approval of that. And so I know a lot about that. I was the PI of the project in the United States. Oxervate does work in promoting peripheral nerve regeneration into corneas that have neuropathic disease, what we call neurotrophic keratopathy or keratitis. The effect is in about 70 to 80%. It is more effective than vehicle, as we published in Ophthalmology about a year ago, in closure of those persistent epithelial defects that don't respond to conventional therapy. It does have a number of side effects that make it, if you will, not the perfect drug. It does cause pain and discomfort in a fair number of patients. The formulation is difficult. So these are shipped to patients and they have to be drawn into syringes and administered by patients on a daily basis. It's not particularly easy to use over a 8-week period, 6 times a day product. Also, NGF can induce a little bit of inflammation in eyes. Quickly, in regard to Oyster's product, this is a cholinergic nasal spray that Oyster Point, a public company, is going to be marketing for dry eye disease. They have embarked on a trial in NK, and there's a question here in regard to its use in GVHD. I think, the answer is we'll have to wait and see. Many of the GVHD patients have minimal to no demonstrable lacrimal function. So their Schirmers are like 0 and 1. And Oyster, I think, is focusing on patients that have some diminished lacrimal function, but not a Schirmer of 0 or 1. And so whether you can squeeze some more function from lacrimal glands by using a strong cholinergic nasal spray, I think remains to be determined. The nasal spray does have a fair amount of side effects, the most common one being sneezing, not surprisingly.
Dr. Dana, what about the concentration of the serum tears and whether platelet rich, platelet poor?
Yeah, no definitive answer there. Some of the worst complications that have been reported in, I can't even call them series, in 1 case here, 2 cases there, have been in the more highly concentrated ones. I don't think that there's any compelling data to show that 50 or even 100% is better than 20%. We know that there is so much protein in the serum that probably going beyond a certain point doesn't provide any additional advantages. And so we're going to stick to the 20%. And again, remember, this is not a very convenient therapy. So you got to balance, so you're going to get this much blood and you hope to end up with this much product for the patient. So you have to keep that in mind as well. You can't just have them come in every 2 weeks for blood draws.
Thank you. I
have a question. Prithvi, what's your experience with choroidal neovascularization associated with NEVI, especially macular NEVI? They're flat, they look great. You see a little bit of subretinal fluid there. All the testing looks okay. Am I supposed to be thinking about anything else besides they seem to respond well to anti-VEGF? Am I worried about something else when I see these things?
Good question. Yeah, really good question, David. I think when I see features of chronic RPE degeneration overlying a nevus, I somehow feel better about it. So the presence of drusen, retinal pigment epithelial elevations, and even choroidal neovascularization just implies that that lesion has been there long enough that it's induced a break in the retinal pigment epithelium, and that's why you're getting this secondary CNV. So on one hand, I'm probably not that concerned that this is a rapidly evolving situation. So that's usually a sign of chronicity. You're absolutely right. You can either observe some of these if they're not causing trouble. You can treat them with overlying laser, PDT, or anti-VEGF, and they respond really well. But the presence of neovascularization on a nevus doesn't portend a worse prognosis to, say, development of melanoma. So usually I usually reassure the patient we have to take care of it, but it's actually probably better in terms of a prognostic standpoint that this isn't going to be something malignant.
Steve, are there other questions from the audience before we go on to the Q&A questions?
I do see that there's one in the text from Dr. McCrae that may be able to be combined with Dr. Schulman's in the Q&A. From Scott, he asks, Dr. Dana, can you comment on flaxseed versus fish oils and re-esterified omega-3s? And Dr. Schulman asks, Dr. Dana, nutrition, diet, metabolic concerns for stem cell patients?
There's a lot of data out there that provides some correlation between diet and ocular surface disease. And we have contributed to that literature from way back in the late 1990s and early 2000s period, looking at large patient cohorts here at Harvard, the physician's health study, the women's health study, the health professional study, looking at nutritional intake and general risk of reported dry eye disease. And there is definitely a very significant relationship in general between what we all know as good diet and the lack of ocular surface disease, or conversely, high omega-6 to 3 ratio and dry eye disease. That, in addition to basic science studies done by our lab and relevant IP held by Harvard on omega-3s, et cetera, et cetera. So we can go on and talk about that at length, and we won't. The problem is that a lot of us participated in the so-called DREAM trial led by Penny Asbell and colleagues, where we looked at the oral administration of high concentrations of omega-3 fatty acid, non-animal derived, in dry eye disease. And the results which were published basically were negative. And we've looked at the data many different ways, post hoc, and there really isn't much of a story to be made in regard to supplementation with omega-3s and a therapeutic effect. So we're back to kind of where we were. And there's a lot of this in the health literature in general. Are people who have health diets? Well, they have a lot of other things, right? They tend to exercise more. They tend to see their doctors more. They tend to, be educated more, et cetera, et cetera. So there is a lot of potential confounders that might be clouding the picture here in terms of general trends. Also, one thing to keep in mind is that the fact that if you're not taking enough of something that's associated with disease doesn't mean that if you take more than normal, that's therapeutic. We tend to make that jump a lot. And of course, that's the underlying force behind the multi-billion-dollar industry on vitamins and nutritional supplements. However, again, the science behind supplementation beyond a certain level is pretty weak. So yes, if you don't have enough vitamin C, you'll get scurvy. If you don't have enough vitamin D, you're going to have issues with bone. But it doesn't mean that if you take a lot of it, you're going to have healthier bone and a stronger immune system. And I think we need to start thinking about that in the same context. So unfortunately, as of today, I'm fairly agnostic. If a patient comes in and says, well, I'm taking, omega-3s, should I stop them? Should I continue? I tell them, I'm like, I don't really know. If it makes you feel better, take them. If it doesn't, don't. That's what I believe in today.
All right, we have another question for Dr. Wozniak. Why is it that getting a productive result from a corneal scraping is hit or miss? What factors contribute to improved results of corneal scrapings?
Yeah, so that's probably multifactorial, but part of it is user, how we do the scraping. Sometimes we feel nervous, especially if it's the eye is thinning or there's a lot of damage there. We might be worried about being too aggressive, with our swabs. But you need to be able to get enough of a sample, for the microbiology group to work with. And then that brings up, there's a period in which you scrape, and then there's a transport period of time where you might have some organisms that die during that that transport time. And then when they finally get into rich media, they try to grow them. It's not a perfect science, let's put it that way. I mean, these are sort of living organisms. So if there's probably steps along the way, I guess my advice in terms of improving results, we've had a really nice results with the e-swab, and a lot of clinical micro labs around the country are switching to that. I find the results a bit better than your typical cotton swab or even the Kimura spatula. But being able to be a little bit aggressive and really making sure you get a good sample is probably your best bet in kind of maximizing your results.
All right, we need to wrap it up unless there are any other questions that are imperative.
I have a question to Dr. Dana, or sort of a philosophical question. So you kind of alluded to diet and lifestyle being beneficial to patients based on all these studies, these large studies. Why not, in a patient that does have dry eye or a severe dry eye, why not use that as a juncture to recommend a healthier diet? And you can't do everything, but when I have these kind of patients, they say, oh, is there anything I can do? The vitamins obviously aren't quite as helpful as we'd like, but I think the data is pretty strong overall that, switching to less meat and dairy, more whole food, plant-based. I use that as a juncture to just say, especially for a patient that I think is really going to change, I say, you can eat more green leafy vegetables, more whole food, plant-based, fresh fruits and vegetables. Get off all the refined foods, or try to wean yourself with a meatless Monday or whatever. Your comments?
Totally agree. But please don't, what I was saying, which perhaps was misunderstood. I think a healthy diet and a healthy lifestyle is not the same as sitting on your couch and popping pills, which is what I was referring to.
Exactly.
I think a lot of people think that by simply taking supplementation, they can make up for not having a healthy lifestyle. So by all means, there is no question. If you've got a hemoglobin A1C and a high body mass index and you're morbidly obese, and all those things absolutely affect all aspects of our health, not just orthopedic, spine, et cetera, and hypertension. And in fact, there is a comment we don't have time to get into about meibomian secretions. There's some interesting data that in fact exercise and being very active can in fact have some beneficial effects to the consistency of your meibomian secretions. So for sure, there are so many benefits to be had, and I agree with you in terms of what we can tell our patients to do or not to do. But I was differentiating that from saying, take, instead of having a healthy diet, just take, 2 more gel caps of omega-3, which is a different thing.
Yeah, there's in the nutrition world, and I follow this pretty closely, there's kind of a shift towards you more whole food, plant-based, because it's the nutritional benefits of this, for some crazy reason, after hundreds of thousands of years of evolution of our microbiome, that whole food, plant-based gets the nutrition, those elements into our bodies better in a more natural form, and we've evolved to process that more healthily. So, I think that we're seeing more and more, less of that, single pill that really doesn't absorb very well or isn't processed as well as whole food, plant-based. I think we're going to see in the future that that's going to be really important for retinal disease, glaucoma. We see it, more green leafy vegetables, less macular degeneration, less glaucoma, ... So I'll get off my podium now.
All right, we're running a little bit behind. I'd like to thank the panelists for their lectures and their participation. It's been a great session. Thank you also for the participants.
Welcome back, everybody. I'd like to introduce the next section, which will be moderated by Steve Felden. As you know, Steve's an internationally acclaimed clinician and basic scientist with a specialty in orbital disease and neuro-ophthalmology, a world expert in thyroid eye disease, and inventor of the tonal pen. He served as our chair here for 19 years, from 2001 to 2019. and literally built this place, leading it to national prominence. And while he still sees patients as a professor of ophthalmology here at Pflaum, he has now ventured into new domains as the Director of Biomedical Research and Development for the University of Rochester School of Medicine and Dentistry, where he also serves as an Associate Vice President. So even though I got to become chair, I still technically report to him. Steve earned his medical degree from the Albert Einstein College of Medicine, and he completed his residency at the Mass Eye and Ear Infirmary, along with a research fellowship in neurosurgery at Mass General Hospital. He also completed a clinical fellowship in neuro-ophthalmology at the University of California Medical Center, San Francisco, and was one of the original faculty of the Doheny Eye Institute at USC under Steve Ryan. He is the former president of the North American Neuro-Ophthalmologic Society and the current executive vice president of the AUPO. And he's also a member of the American Ophthalmological Society, but most of all, he's a mentor, colleague, and friend. Steve, it's a pleasure to have you moderate this session. Please take it over.
Thank you very much, David. It's a pleasure, and I can assure you that the feeling is mutual. It's great to see you doing such a great job as chair and bringing the next level of growth to the Pflaum Eye Institute. So I'd really like to welcome Joyce Lau. Joyce is, of course, a colleague. She's Associate Professor of Ophthalmology and Neurology at Stanford University Medical Center. She is a clinician scientist dedicated to make basic discoveries and improving clinical care and treatment of patients with neuro-ophthalmic disease. A major focus of her research is in the understanding of conditions that lead to retinal ganglion cell loss and irreversible thinning of the optic nerve, including hypoxic, ischemic, autoimmune, and other causes. This includes developing state-of-the-art imaging tools to identify biomarkers in the anterior ischemic optic neuropathy, as well as looking at subcellular changes following optic nerve injury. Her approaches are aimed at developing therapies for optic neuropathies, including neuroprotection and regenerative therapies. She is also involved in the clinical assessment of visual function and vision rehabilitation. She uses eye behavior to understand how different neuro-ophthalmic diseases impact visual function with the aim to design better visual rehabilitation strategies to help improve their visual function and quality of life. Dr. Lau received her undergraduate degree with high honors from Harvard University in biochemical sciences and her MD PhD in neuroscience through the Medical Science Training Program and Fellowship in Neuro-Ophthalmology from the University of California, San Francisco. She serves as director of the Neuro-Ophthalmology Service and Neuro-Ophthalmology Fellowship, as well as co-director of the Vision Research Training Program. She is also director of Stanford's Optic Disc Drusen Center. And her first lecture today is on oscillopsia and diplopia. Joyce, welcome. We look forward to your talk.
Thank you so much, Steve. It's such a pleasure and honor to be part of the Rochester Ophthalmology Conference. I hope you're enjoying it as much as I am. I'm going to go ahead and share my screen. Okay, so we are going to discuss oscillopsia and diplopia first, and then we'll get to the optic nerve and retinal ganglion cells at the next talk. I'm coming to you from Stanford, California, and I have no relevant commercial financial disclosures for today's talk. We are visual creatures. We use vision and eye movement working rapidly together in order to bring the world to our eyes, which is then interpreted by our brain. If we look at the eye movement, this is how we look at the world. We use this process called foveation, which aligns the most sensitive part of our eye, which is the fovea, with the region of interest. And in this way, I'm rapidly looking at this painting or an interesting part of the scenery and generating a attention heat map. This is basically where I actually looked at and So the patients with double vision and oscillopsia, they have difficulty with this process of eye movement control. So today's lecture will focus on some simple goals, which is to learn about eye movement control. We'll have a lot of fun to look at patients, how to approach them, the ones that will have eye movement disorder manifesting as double vision or oscillopsia. The eyes move by control of 3 cranial nerves and 6 eye muscles on each side. And this process is regulated by the brain. So if you look at this image of the left eye, we basically look at all these predictable directions, which are controlled by cranial nerves 3, 4, and 6. And then we can move and coordinate the 2 eyes together. When a patient has double vision or oscillopsia, you think about, well, where is the problem? Is it the muscle, such as something called chronic progressive external ophthalmoplegia and mitochondrial disorder? Is localized neuromuscular junction, the nerves, brainstem, or sort of a higher order brain control centers? Let's look at how we examine eye movement. And so this is a healthy control subject performing version or moving the 2 eyes together. And she's looking left, right, top, and then bottom, and then converging. So her head is nice and stable, and you're focused on just her eye movement. So in contrast, some of your patients may do this. Which is they move their head as they're moving the eyes, makes it difficult to examine. So make sure you stabilize the patient's head and only move the eyes. So I usually start when I look at a patient with double vision or oscillopsia with a basic screening eye movement examination. So I look at them with the eyes open, both of them together. And I start with some just sort of simple things. Look at the Snellen chart at distance, fixate on this single letter. Can they do that well? Stable fixation. Then I look at a range of movements, such as what you just saw, looking left, right, up and down, and I'm assessing smooth pursuit as well as the range of their movement at the same time. And if you need to have them repeated to make sure you really saw what you thought you saw. I also had them assess reflexive saccade, which is to look between 2 large targets like my finger and a pen. And I'm having them look left and right, as well as top and bottom. You could assess this in sort of fancier ways by looking at diagonal eye movement, small saccades versus large saccades. But basically, can they look, hold their eyes steady, and then can they move them rapidly in precise ways? There are other things that I could assess, but I don't consider them part of the basic rapid eye movement exam. And then you want to look at alignment, because this is actually how we look at the world. 2 eyes aligned together, looking far away, such as when we're driving or watching TV, or when we look up close, like looking at a computer or reading a book. So we want to know if the patient is able to converge in a way that is able to align the 2 eyes at near. Or can they look far away and align the eyes very well at distance? So this will give you different patterns of eye movement and eye alignment issues, which is assessed most precisely by cover-on-cover tests or the Maddox rod. And you're looking at the patterns. Is the alignment appropriate, meaning orthophoric? Is it misaligned in a horizontal, vertical, or other ways? And is the pattern the same, meaning comitant in all directions of gaze, or is it incomitant, meaning it could be a nerve, a muscle, or another problem? So let's talk about binocular diplopia in a moment. So here's a patient who is a 70-year-old smoker with acute binocular diplopia. He complains of horizontal double vision, And when you have him move the eyes, you can see that the left eye does not abduct. And this is due to a left cranial nerve palsy, giving you an incomitant left esotropia, meaning it's worse on left gaze. And Dr. Williams is going to go into esotropia a little bit more. So essentially a horizontal diplopia, worse with left gaze and better with right gaze, consistent with the paresis of abduction. So I'm not going to go into the alignment too much, but this is just a slide to remind everyone that you want to look at the alignment using the cover-on-cover test or the alternating cover-on-cover test in order to assess competency. And so looking straight, left, right, top or bottom, especially in a near and reading gaze is really important. Here's another patient. He's a 27-year-old man with double vision after a motor vehicle accident. And what you see is there's a left ptosis and mydriasis. And when he looks to the right, the left eye does not adduct as well. And then when he looks up and down, the left eye does not go up or down very well. And this is from a left cranial nerve 3 paresis, giving this combination of left ptosis, mydriatic pupil, and this patient has a left exotropia and hypotropia, and it's worse in the direction of the action of cranial nerve 3. This is another patient who has a history of left cranial nerve 3 problem. And you could see the left ptosis and the thalaparesis, and that ptosis corrects itself when he adducts as a result of aberrant regeneration. So if you have a patient who is exhibiting these signs of aberrant regeneration, you absolutely want to image them, because this is not a diabetic third. And this is, could be a tumor, an aneurysm, or something else. So keep in mind these exam features. Let's look at a patient with bilateral symptoms. So this is a 65-year-old woman with bilateral ptosis and evolving binocular diplopia. So she's looking all the way to the right, but not able to completely look all the way to the right. And she looks up, and there's some fatigability of up gaze. This video does go pretty fast, but she looks down gaze fairly well. And so this is a patient, and you can also see the folds of her forehead. She's really struggling to keep those eyes open. This is a patient with myasthenia gravis who has a combination of fatigable weakness. So she has bilateral ptosis, which is very classic, as well as bilateral ophthalmoparesis. And this test can be confirmed, this diagnosis can be confirmed using a simple test using ice pack. So this is her eyelid position before the 2-minute ice pack test. She basically just closes her eyes and takes a little short nap with the ice pack over the eyes. And then her eyes pop open immediately. And this is a very characteristic exam finding in myasthenia gravis. So far we have some cranial nerve examples, myasthenia gravis. So let's march on to look at some patients with saccade abnormality. So this is what a normal reflexive saccade should look like. This healthy control is looking left and right rapidly. And if you look at a patient who has difficulty with this process, you'll see this is an example of hypermetria. So there's an overshoot of this reflexive saccade past the target and then coming back again as a result of cerebellar ataxia. And another example of saccade abnormality is illustrated here. This is a patient with medulloblastoma, and eye movement recording, basically looking at the horizontal, and the middle is the vertical or the torsional. These are the 3-dimension of eye movement. You could see what hypermetria looks like on an eye movement trace. So they shoot past the target and oscillate, and then stabilize in a desirable position. And so every direction they look, there's this overshoot and incoordination of the eye movement. Here's a patient with very slow reflexive saccades. So she's looking back and forth to her right and then left. And basically you can see it's so slow that it almost looks like a pursuit movement. They're relatively close together. Now look at the finger. And I'm having her look at different directions and different sizes of reflexive saccades. This is a patient with spinocerebellar ataxia type 2. And so ataxia symptoms can manifest as hypermetria and sometimes a combination with hypometria, depending on the size of these saccades. Let's move on to oscillopsia. So this is what oscillopsia looks like when you're reading the Bible of neuro-ophthalmology. And oscillopsia is actually very simple. It's basically difficulty holding the eye still. So you have a system in the brainstem that tells you to move the eyes or not. And essentially, this system needs to be stabilized by a series of sensory inputs. And people who have trouble doing that basically have oscillations of the eyes when they cannot hold the eyes still. So there's a drift and then a shift to correct that drift, which sets up with this waveform of nystagmus or saccadic intrusions, or these oscillations of the eyes. And when you look at the different types of nystagmus, everything that you kind of need to know is listed here. This is my go-to slide for teaching residents. So there are different types of nystagmus and oscillations of the eyes. Essentially, it has to do with inability to hold the eyes still, to perform fixation. So let's look at a patient. This is a patient who has downbeat nystagmus, and he's going to look to the left. And you can see this downbeat in the fast phase. And he's then going to look to the right, and you'll see that there's also this increase in downbeat nystagmus, a very characteristic pattern for downbeat nystagmus. And when he looks up, the nystagmus is quite good. So that's where the eyes want to be. And so it's better with up gaze. And when he looks down, it's worse again. And I think there you go. You can see that bounce as well. So here's a man with upbeat nystagmus, and what you see is the fast phase is upwards, and there's also a gaze evoked nystagmus to the left as well as the right gaze. Here's a woman with saccadic intrusions from medulloblastoma. She's the one whose trace I showed you earlier. And you just see this fast back and forth horizontal oscillations of the eyes. And that's, there's no slow phase. So that's why it's a saccadic intrusion, typical of cerebellar ataxia, such as from medulloblastoma. And here is a man with seesaw nystagmus, and you can just see this back and forth oscillation with occasional kind of a rocking motion. That's the seesaw component. He also has gaze evoked nystagmus, and this has broken down. So this is a congenital nystagmus that got a little worse, and he needed to be treated with medication to dampen the oscillations. And then here is a man with multiple sclerosis, and you can see this just sort of back and forth little jumps of the eyes. This is related to bilateral intranuclear ophthalmoplegia that is so severe that you can actually manifest it even just looking straight. And then when he looks to the left and to the right, you can see this classic difference in the abducting eye versus the abducting eye with the abducting nystagmus. So this is multiple sclerosis. And here's a dog. This is actually Dr. Ted Cooper, a neuro-ophthalmologist at Stanford. This is his dog with a jerk and nystagmus feeding to the dog's right as a result of vestibular neuronitis. So you could have dynamic eye movement issues. And so we're putting together fixations and saccades in order to look at the world in precise ways. So this is what a control subject may look at when they're doing the reflexive saccades. And here's a man with traumatic brain injury. You could see the fixations all over the place. And the saccades are mostly good amplitude and velocity, but a little bit off certainly. And so when we read, we use alternating saccade and fixational movements in order to be able to perform these tasks rapidly. And so when we look at the world in this way, you can assess it using a predictable pattern, such as a number reading task like this. And so a control can do this rapidly and precisely, while a patient with Parkinson's disease, for example, may have difficulty with this task. And you can see how large the circles are in, when they started to read, and then things kind of speed up a little bit. So when we look at the world, it's no longer this precise pattern of left to right and top to bottom and a reading pattern. Here is a bunch of middle schoolers just looking at this nature video, and each heat map, little hotspot, is a person just looking around at these beautiful scenery. And if you look at the attention map, you can see that it's actually quite different for different people. And if you look at the same subjects watching a movie, you could see a much more coordinated and predictable pattern. Basically, we're looking at wherever the exciting things are happening. And so when we look at the same 4 people with this predictable pattern, you see that they're mostly looking around the center of the screen. So to summarize, eye movement control depends on foveation, which is a coordination of vision and eye movement that allow us to see the world. This is controlled by 3 cranial nerves and 6 muscles. So each of them, if have a issue such as an eye or neurological issue, can give you double vision. We perform these activities of daily living by rapidly moving our eyes, and you would have moved about your eyes probably at least 3,000 times, within the span of my lecture. And so this is really the eye movement pattern depends on our intent, and this is affected by visual field defect. So don't forget, do the rapid 1 minute eye movement exam, looking at fixation, pursuit, version, saccades, and alignment. And when you look at patients with double vision, see if it's comitant or incomitant, and is this worse at distance or at near, and whether you need to have brain imaging as part of the workup. Don't be afraid of oscillations of the eyes. It's actually pretty simple. You just need to figure out why the patient cannot stop moving the eyes. So make sure you take a stabilized eye movement video when you examine the patients using a phone or a camera with some good light and magnification if need be. So thank you so much for your attention. And I would like to take some of your questions later on at the end of this session.
Joyce, thank you so much. That was a very comprehensive, elegant, and succinct lecture on a very tough topic. So I'd like a copy to show to the residents on a weekly basis and remind them. And now it's a pleasure to ask Dr. Lau to give her second lecture on anterior ischemic optic neuropathy diagnosis, state of research, and treatment. Anxious to know how to deal with it. So Joyce, looking forward to it.
It's a pleasure to give the last talk for this wonderful conference. It's going to be on ischemic optic neuropathy. So again, no commercial financial disclosures, and this study was supported by various sources. Anterior ischemic optic neuropathy, and I'm only going to talk about the non-arteritic form. This is the most common acute optic neuropathy in those older than 50. Risk factors include vascular risk factors such as hypertension, diabetes. There's also anatomic risk factor or so-called disc at risk, such as an extreme form as a result of optic dystrusion, as well as hypoxia, such as sleep apnea. So there's about 6,000 new cases of AION, the non-arteritic form, per year. And there's an increased risk of this as a result of intraocular procedures, most commonly in cataract surgery. Here's an example of a patient with sequential AION with altitudinal visual field defect, diffuse swelling of the optic disc, and this halo of decreased perfusion on fluorescein angiography in the setting of swelling of the optic, the peripapillary area. So let's talk about it a little bit. Basically, this slide summarizes how to manage patients with AION. This is thought to be hypoperfusion of the anterior optic nerve in a mechanism that still remains unclear, but it seems to behave in a way that's consistent with a white matter stroke, very sudden onset, typically with relatively irreversible changes. The diagnosis is based on clinical history and examination and ruling out of inflammation, such as the arteritic form of AION in the setting of giant cell arteritis, or ruling out other causes. There's currently no effective treatment, but we're sure hoping to make a difference there. So today I'm going to talk about three studies. The first two are actually basically cases. And the third one, these are three different clues on different aspects of disease that will hopefully lead to effective therapy in the future. So first, I'm going to present a case on high altitude associated with AION. Second, one that's associated with optic dystrusion in a young onset case. And then looking at the question, whether there is inflammation in the setting of non-arteritic AION. So first, hypoxia. This is a case of a 48-year-old man, very healthy, athletic. He went hiking at Sierra Nevada, and 3 days into his hike, which is at approximately, over 2,000 meters, where he was breathing 26% less oxygen per breath. He noticed a decrease in his vision. And I saw him 8 days afterwards, where he was found to have visual acuity of 20/20 and an inferior altitudinal visual field defect in the setting of diffuse swelling of the optic nerve. Note the presence of an optic disc at risk on the other side, which is characteristic. So this patient was diagnosed with high altitude associated with non-arteritic AION. And it actually inspired a study in my laboratory. Just briefly to tell you that the perfusion is exemplified by a different modality other than fluorescein angiography using the OCT angiography, show in the setting of swelling that there is actually areas of hypoperfusion superiorly, which correspond to the inferior field defect. And this patient did unfortunately have a poor outcome with severe vision loss and severe dropout of the superficial capillary density. So in hypoxia and in high altitude, this is called hypobaric hypoxia. Essentially, we are breathing the same level of oxygen, but the effective oxygen getting into our cells is reduced. So at Mount Kilimanjaro, for example, we're effectively breathing 10% oxygen instead of about 21% oxygen. And then Mount Everest, obviously, no one should honestly climb that without oxygen. So at University of Rochester, at the observatory, we're at about 700 meters, and none of us should have any issues. At commercial aircraft, this is actually now beginning of some altitude effects, because it could be about 200 meters, approximately 6,000 to 8,000 feet. equivalent of high altitude. When you get to higher altitude, you start to have this hypoxia-inducing symptoms of acute mountain sickness or cerebral edema. And in extreme high altitude, there's certainly well-documented cases of optic disc edema, thickening of the nerve fiber layer as a result, including cases of ischemic optic neuropathy. So most people do actually okay in high altitude with hypobaric hypoxia, but you could absolutely get transient or permanent visual disturbances or loss. So the hypothesis is that hypoxia itself is somehow triggering optic nerve ischemia. So we looked at this in the animal model by using a hypoxia chamber. In this study, we looked at 48 hours of hypoxia at 10%, which is equivalent to Mount Kilimanjaro. We looked at the retina and the optic nerve. And what we found is that 48 hours of spending equivalent time at Mount Kilimanjaro without oxygen seems to lead to no significant changes in the retinal ganglion cells. We count them, they're still there looking fine. There's also no evidence or very little evidence of cell death consistent with that finding. If you look at the optic nerve, however, it's interesting. The most striking findings actually has to do with glial changes. So I want to show you both the retina, which is in the middle here, as well as the optic nerve. So in the retinal ganglion cells, there seems to be increased expression of this marker of endoplasmic reticulum stress. This is how we regulate protein synthesis. And the increase staining is consistent with increased cellular stress. And the cellular stress seems the most profound at the unmyelinated optic nerve. And as you can see in the green here at the cross-section of the optic nerve head. And so when we quantify this, essentially there's increase in the retina, increase in the unmyelinated optic nerve, and relatively not changed in the myelinated portion of the optic nerve. There's also astrogliosis as evidenced by the increased expression of gliofibrillary acidic protein. And this is coincident with the area that has the highest CHOP expression, or presumably highest cellular stress. So we looked at this in a longer hypoxia model. So this is 1 week, and looked at the plasma, and we found that this stress is actually accompanied by a relatively systemic increase in immune molecules. There is 10 significantly increased molecules in the plasma and 4 in the retina. And if you look at the overlap, VEGF and interleukin-1 beta are the two that are both present, suggesting that those may be some of the most important ones in mediating hypoxia-induced swelling and ischemia of the optic nerve. So the current model of AION actually has to do with more of the glia. Hypoxia leads to a failure of oligodendrocytes. I didn't show you the data, but there is early death of oligodendrocytes and activation of the astrocytes, as well as inflammation. That leads to a failure of retinal ganglion cell axons. Recall that AION is an axonopathy. And so if you look at this diagram showing all different components of the optic nerve, essentially there's a failure of energy in the axon as a result of poor support by the glia. And when these things fail, that leads to ischemic optic neuropathy. So the second topic is on an example, a case of optic disc at risk as a result of optic disc drusen. Optic disc drusen is the most common risk factor for young onset AION. So this would be onset at younger than 50 years of age, for example. And optic disc drusen is an extreme case of crowded disc. Here is a case that's published, and what you see is a baseline. This patient is a 25-year-old woman with bilateral optic disc drusen. I'm showing you the color fundus imaging on top and the near infrared reflectance imaging on the bottom. When she developed sudden vision loss in the left eye, this is what her nerve looked like. There's a fullness that then is superseded by all this fluid. And you could see that really nicely on the near infrared reflectance imaging. This is with confocal scanning laser ophthalmoscopy, or CSLO. After the edema abates, then you could see actually new pallor at the optic disc, consistent with optic disc drusen associated with anterior ischemic optic neuropathy. When you look at the visual field, this is what the patient looked like. There's a new inferior field defect compared to baseline, and this persisted in the chronic stage. And there was an original swelling, as we saw in the picture earlier, and leading to thinning. So there was some thinning essentially as a result of optic disc drusen. With the AION, there's an increased swelling or pseudo-normalization of some of the measurements, and then a more severe swelling, thinning afterwards chronically. So we think that in optic disc drusen, this is giving us a hint what's happening with AION. So there's some unknown process, probably in development, that leads to ectopic calcification, specifically in the mitochondria, that then gets extruded into the axon. And so this is actually now extracellular. These then coalesce, enlarge, and get bigger, forming these optic disc drusen, severe crowding. And then all you need is some another risk factor, such as hypertension, unhealthy blood vessels, sleep apnea, giving you some transient recurrent hypoxia, or other issues that will then trigger an actual event leading to ischemic optic neuropathy. So it's interesting that, we think about the disc as being sort of the crowded in an extreme sense in optic disc drusen, but there's actually well-documented histologic abnormality, and then more recently imaging abnormality of blood vessel changes in optic disc drusen itself. So it's possible that without overt AION, that there's actually an ongoing vasculopathy in optic disc drusen. So this is a image from Mark So's seminal paper, where you see this enlarged perivascular space around blood arteries and veins. And then in a multicolor imaging example of another patient, you could see this increased green hyperreflectance throughout the papillary vessels, more in the arterioles. And essentially, it will be interesting to be able to study this much more. So crowding as a result of optic disc drusen, leading to vision loss. We're studying this at Stanford, and everyone is welcome to our meeting that's coming up on May 17th, 2021. It's a Monday, and it's virtual and free. So last, I want to address the inflammation. So non-arteritic AION is classically thought of as a non-inflammatory disorder. That's exactly how we distinguish it from other conditions. However, there's really no established biomarker for AION. And we know that at least at a local level that there is some inflammation. And so there's some literature on this topic, essentially how ischemia and inflammation kind of plays this vicious loop of further axonopathy leading to actual vision loss. So there's been 3 studies prior to ours that looked at and showed that in human or mouse AION, this is in the acute setting, that there is increase in some immune molecules such as interleukins, VEGF, et cetera. So we wanted to look at inflammation in a more comprehensive sense, and specifically looking at plasma, because that's the easiest specimen for testing for biomarkers. We recruited the study that is about to be hopefully published, looking at 27 study participants, and we've now collected 53. So these are control subjects, acute AION, chronic unilateral AION, and chronic bilateral. So the patients are seen in clinic by me and then recruited to have their blood drawn. We also have healthy controls. Now it's 10. Actually, so around the time of cataract surgery, when the patients are already fasting and do not have a ophthalmic disorder, the blood is processed rapidly within 1 to 2 hours for plasma. And we look at, in this study, the plasma using a Luminex array, looking at 76 immune molecules, which is a much more comprehensive way than the small number that was done previously. So here's one patient that we were able to look over 3 different time points. And this is just a profile of the 76 molecules. And you can see that some things go up, some things come down, and there's certainly a patient-to-patient variability. But what we found in these 27 subjects is that there were some surprises, actually. So recall, we were looking for biomarkers specifically for acute AION, and we did find that there were significantly increased molecules in acute AION, but surprisingly, there were quite a few in the chronic setting as well. So in total, there were 20 significantly different between the 2 groups, which then we looked at using hierarchical clustering and found that there was segregation of some of the immune profiles with disease status. We also looked at principal component analysis to look at segregation of these profiles. And it was interesting that if you look at the cluster, and granted, this is kind of the first study, so the numbers are not large, but the controls, which are in black, are primarily in one cluster, whereas the acute patients are in a different cluster, and then the chronic patients are in a different cluster. And that patient whose eye that I showed earlier and whose profile I showed earlier, in the week 1, when he was in incipient AION, he was profile is located here. Week 2, he was sort of smack in the middle of the queue. And then week 12, he was actually transitioned to the chronic setting. So it gives you an idea that this pattern of immune changes may reflect the disease itself. So in summary for this section, we did plasma immune profiling, which shows some significant changes in 20 immune molecules consistent with inflammation in the acute as well as chronic AION. And we looked at this one patient in particular. There's only 15% overlap between the acute and the chronic AION group. And so we actually don't know what the significance is. And we're doing a more detailed proteomics analysis with a larger cohort and mass spectroscopy. So of the 20 that were highlighted, CXCL10 and interleukin-2 after adjusting with Panferroni correction were the strongest biomarkers and likely to be highly promising in the future for non-arteritic AION. So in summary, I showed you 3 different stories. One, looking at the hypoxia component of AION using studies on high altitude associated AION, and found that there were glial changes most predominantly in a way that is related to increase in the plasmic reticulum or cellular stress and inflammation. Young onset AION is a story about extreme dis at risk kind of situation, and we think the crowding and the vasculopathy as well as glial dysfunction are likely involved in triggering this condition. So we already have some wonderful targets here. And last but not least, non-arteritic AION is absolutely associated with probably not just local, but also systemic inflammation in a low-grade way that seems to evolve from acute to the chronic phase. And so, these are all potential things that we could target in the future. So axonopathy in AION, essentially, we're looking at intracellular and extracellular stress as a result of hypoxia, disease, mitochondrial issues, calcium dysregulation, or toxins and medications. And how the cell deals with it basically determines whether we survive by restoring homeostasis and endoplasmic reticulum and other metabolic function, or it leads to cell death and inflammation. So in these eye-brain diseases, we think about the eye bringing the information to the brain, which gives us vision and our human experiences. So AION is a disconnection of that circuit. And so we hope that our studies will eventually lead to ability to detect at the earliest possible time point, perhaps before people actually lose vision, so that we could intervene with novel treatments. So thank you.
That was terrific. Thank you very much. I was hoping you had the answer, but I guess we have questions. Which
Next
is
year.
Probably the next best
Next
thing.
year.
So let's see, we have time for some questions and answers. And there are a couple on the list here. So Zoe, Peter Schwartz is asking whether you consider Botox at the present time for your patient, and given the the complete disconnect of the muscular tissue. So you have a response for that?
Yeah, I think it's a great suggestion. He's really anxious to have something permanent and get back to his life, given that he's got a low life expectancy due to his GBM. So I'm hoping that we can do a little more at surgery, but it's not a bad idea to consider also Botoxing the medial at the time of surgery. Absolutely.
Great. And remember that, Reza Dana is still here, anxious to answer questions for everybody. There's a question from Kathy Ewan for Dr. Lau. So aside from counseling young patients with optic nerve drusen about controlling systemic factors, do you think there is value to performing visual fields annually, or would changes only be observable if they're in the active episode of NAION?
Good question. So these are patients we follow over long term, and the assessment is quite important. Visual field is a relatively insensitive way of picking up progression in patients who have no symptoms. And that's because the majority of patients with optic disc drusen actually have very little visual field defect. And we looked at this and segregating field versus OCT and OCTA measurements. And we found that honestly, the best way is to follow the guideline of the Optic Disc Drusen Studies Consortium, which is to perform ophthalmic imaging. So this includes enhanced depth OCT, and we've shown recently that on FOS, multimodal imaging is also an effective way. If you look at the latest publication from Denmark, from Stefan Hammond's group, they show in some beautiful examples of how enhanced depth OCT can show you this enlargement of the drusen or the anterior migration of the drusen in the Copenhagen study, looking at a large number of children over time. And so I would think, if you could do all of it, that would be great. But for sure, the easiest way to screen for changes is to look at OCT and on-FOS imaging.
Joyce, I had a question for you about your eye movements. So can you tell me what you think today is the clinical value in doing eye movement recordings, and whether advanced eye movement recording, scan paths, other things will be part of our future armamentarium, or whether this is primarily a research tool?
So great question. Actually, eye movement recording is a daily part of an ophthalmic clinic because that's part of imaging. So we are always, tracking eye movement position as part of being able to image well, and certainly part of visual field assessment. And I think eye movement and recording and assessment of gaze is going to be an increased part of our regular daily lives, because there are multiple companies, some in Silicon Valley, some elsewhere, who are trying to leverage eye tracking in order to better deliver a gaming experience in the virtual reality world, or assessments. So I think in general, ability to track eyes will tell you a lot about vision and visual function in objective ways. So I myself, I think the part that I appreciate the most doing eye movement recording is it teaches me how best to see my patients with eye movement disorders. You know, it's kind of like a training. You do the recording and it's really easy because instead of just looking at the patient, you have this three-dimensional output of what their eye positions are over time. And so it really helps with a diagnosis. I'm actually working with a group of people who know more about artificial intelligence than I do. And we're looking at the eye tracking patterns from the number reading test, the King David and variations, to see if we could use this simple number reading test as a way to predict who has eye movement abnormality or vision abnormality using a AI-based kind of aspect. So, you know, yes to essentially every aspect, the eye movement recording and understanding of eye movement will greatly enhance our understanding of disease and visual function.
Thank you. Other questions to the panelists?
There was a question we missed earlier for Dr. Dana. It was a question about meibomian gland function and the best way to restore meibomian. Is there a way to restore meibomian gland function and improve the flow?
Yeah, thank you. I saw that question earlier. Thank you. I think the key thing in all chronic disease is to intervene early. And what we end up seeing, in particular, those who are not very familiar with diagnosing meibomian gland dysfunction, what we call MGD, is that we diagnose it when it's too late. When the majority of these orifices are closed and scarred, there's really not a whole lot that you can do. We can still utilize oral tetracyclines like doxycycline to suppress MMPs and inflammation, but we really can't change anything about the consistency of the tear film. When it's early, and especially I think in the question there was something about aging, it's true, young people tend to have clear secretions and older people tend to have more viscous secretions, and they also tend to be not as clear. We used HPLC many years ago, and we've looked at this in publications dating back to the late 1990s, early 2000s period. Some of those changes are normal, but the key thing is that there is a change in the consistency and composition of the meibomian secretions with age, also with diet. And generally, we were talking earlier about, for example, omega-3s and omega-6s. In general, the healthier and the younger that you are and the better the diet, the lower the cholesterol composition that you have in your meibomian secretions. And that affects the melting point of these fats. So when the melting point goes up, that also contributes to clogging of these orifices. And then lastly, within that question was something about application of heat, the Bruder mask, etc. You know, when we looked in the meibomian gland workshop a number of years ago at prospective studies at what really does help meibomian gland treatment, actually the application of heat was the only one that had withstood true investigation, and that was done by a number of Japanese groups. So I do believe that as perhaps unsatisfying and unscientific it may appear, application of heat for long enough, that's the key point. It has to be long enough. When you tell people hot compress, whatever, people sometimes splash hot water, or they're like, oh yeah, doctor, I stand under the hot shower and, you know, rub my eyes. That's not application of heat for 10 minutes. But if you do apply that twice a day, 10 minutes or longer, over time, it absolutely does change the ability of the orifices to permit the egress of meibomian secretions, but it has to be done before they're all closed.
Thank you. Let's see, there's one more question for Dr. Lau. To comment on the utility of King Devic screening tool for concussion, Parkinson's, et cetera.
The King David test is, I think, at this point, well established as one of the good screening tools for concussion. There are many others that there's some fantastic work done by the NYU group looking at instead of single digit number, looking at pictures. So essentially what I really like about these tests is that they're quantitative. You could do the King David test in about a minute in a healthy control person. And in someone who is concussed or have a neurological disorder, it really wouldn't be much more than 2 minutes, so it is quite useful even on just tracking the same person over time. And they've certainly done studies looking at neurology residents post-call, for example, how their King David reading speed actually worsens post-call. And so essentially, I think it's a useful test for people who could do this on their own. Sometimes I have patients who report to me, how they're doing and what their numbers are just as a screening tool. So I think it's useful. And I think in the future, we're hoping to have easy tests like this that can be implemented at point of care locations like the eye clinic. I'm hoping one day we could really change the people's, the doctors or technicians anyway, workflow in a way that, everyone would systematically have these easy reading or, oculomotor tests performed.
Terrific. We're just exactly on time. So I'd like to thank Joyce and Zoe for great neuro-ophthalmic education, and Reza Dana for his fantastic opportunity to get up to date on corneal and external disease. And I'm going to turn it back over to Dave DiLoretto and thank him for just a wonderful Rochester Ophthalmological Conference.
Yeah, thanks, Steve, very much for moderating. And Joyce, Zoe, and Reza, thank you very much for a great ending to a great conference. To all attendees for participating, thank you. To all speakers, thank you. Moderators, thank you for taking the time and preparing for this. Just a couple